We have a long-standing interest in intrathecal therapy, also for children with brain tumors. And my second interest is relapsed tumors, such as relapsed medulloblastomas and atypical thyroid rhabdoid tumors, and treatment with an anti-angiogenic metronomic therapy for these patients. Most systemically administered drugs do not reach the CSF at appropriate levels. Most of the drugs only achieve like 10% of the level they would achieve in the plasma, in the CSF, and therefore direct application to the CSF is important to reach cytotoxic levels of the drugs. The parent drug of cytarabine has been used for many years for intrathecal therapy and also for systemic therapy in leukemias. But leukemias are faster growing and faster dividing cells, and cytosine arabinocyte is an S-phase specific metabolite that only works in mitosis. Solid tumors are slower growing and have a poorly characterized threshold cytotoxicity, which is considered to be 1 or 2 logs higher than for leukemias. And therefore, dose of application and exposure time are important for efficacy in these tumors. We've actually been using it on a variety of pediatric brain tumors, primarily in recurrent medulloblastomas and in recurrent atypical thyroid rhabdoid tumors, concomitant with a metronomic anti-angiogenic therapy. Because if you use metronomic anti-angiogenic therapy, you do not reach the CSF with this therapy, and tumor cells floating in the CSF cannot be attacked by this type of therapy. Because we were using liposomal cytarabine since 2004, we also did and all our patients have Ommaya reservoirs in place. We did pharmacokinetic studies on our patients. There were no studies on children under the age of 3 years available before, and only very limited data on children above the age of 3 years. But we could show that if we choose a dose of 25 milligram for children under the age of 3 years, 35 milligram for children 3 to 10 years old, and 50 milligram for children above the age of 10 years, that it seems to be safe and that we can achieve comparable elimination rates to the elimination terminal half-lives of the drug in adult patients. We cannot judge the effect of liposomal cytarabine independently, because all of our children have also been given either metronomic anti-angiogenic therapy or conventional chemotherapy. But 2/3 of the patients who have been treated with this approach are still alive, and 1/3 of these patients off therapy. Not all of these patients had recurrent tumors, but the ones that didn't have recurrent tumors had highly malignant tumors, such as atypical thyroid rhabdoid tumors. So and none of the patients died of leptomeningeal disease with respect to tumor cells in the CSF. So it was usually the primary tumor that was not containable. We did observe side effects of liposomal cytarabine with regard to chemical meningitis in approximately in actually 13 of the 66 patients. We observed increased intracranial pressure, which was easily treatable though with evacuating lumbar punctures. Most of these children only required 1 evacuating lumbar puncture, a few 2 lumbar punctures, but this was usually easily manageable. In a few patients we also observed a transient decrease in short-term memory, transient decrease in visual acuity, and transient decrease in hearing. All of these side effects improved after discontinuation of the drug and did not preclude restart of the drug 6 weeks to 3 months later. It is not yet a standard treatment, but I think it's an option, particularly for patients who had received prior craniospinal irradiation, for whom methotrexate is not an option because of the risk of leukencephalopathy. We usually use liposomal cytarabine alternating with intrathecal etoposide, and by alternating it, we space apart the administrations of cytarabine, and I think this also decreases the side effects of cytarabine.